Hi, thank you very much. Yes, so my name's Isabel. I'm one of the bone marrow transplant nurses at King's College Hospital in London. Thank you very much for inviting me to speak here today. It was because of a talk I did in London last year for the data managers that I got invited here, and I feel privileged to be standing here. So when I was first given the topic of talking about full blood counts, I thought, how am I going to talk about that for any length of time? And then I thought a bit about my approach towards it. And I'm a nurse, and my patients ring me all the time asking me for their full blood counts. So obviously it's important to them, so it should be really important to us. So I'm going to make this a very nursey approach, very patient-centered, and I'm going to explain full blood counts how I would explain it to a patient, to a friend if they asked me, and to a family member if they were interested. So this is me, and I have no conflict of interest. So how I'm going to broach the topic today with an agenda and some learning outcomes. So what is included in a full blood count, the normal ranges, and the use of a full blood count in diagnosis, during treatment, and because we're here at EBMT, of course, transplant, and the very important engraftment. So what is a full blood count? So it's looking at the number of cells that are produced by stem cells which are found in the bone marrow. So a stem cell is the mother cell. Here it is. So when looking at the mother cell, it can go down one of two routes, and ultimately they create the red cells, the platelets, and the white blood cells. So the red cells, or the hemoglobin, it's this squishy, concave disc, and its main job is to oxygenate all of the organs in the body. The normal hemoglobin is 130 to 180 in men, and 120 to 165 in women. My values all come from the Bloodwise website, so things might change depending on protocols and local protocols as well. And like I said, its main job is to carry oxygen around the body. So next are the white blood cells. So those are all of these cells, the total count of all of these in the bloodstream, working together. And a normal white blood cell count is 4 to 11. And their main job is to work together and to fight infection. So let's look at the neutrophils. Here they are in the middle. Their main job is to target bacteria and to target fungus. A normal neutrophil level is 2 to 8. They make up 60 to 70% of the circulating white blood cells, and they're usually the first responders to a microbial infection. They are there first on the scene, and their activity and death in large numbers forms pus. So think of that spot you squeeze, and the pus that's produced, that's the work of the neutrophil. So that bacteria there is actually Streptococcus, a common throat infection. And that there is Aspergillus, a fungus infection that often affects the lungs. Now on to the eosinophils. So these are inflammatory cells, and they are important in allergic reactions, and they make up 2 to 4% of the total white blood cell counts. They target parasites. This parasite here is Toxoplasma, and that comes from cat feces. So maybe you'll think twice about having your cat litter tray in the house or having your cat in the bed. Now on to the basophil. Basophils are what sound the alarm that something is going on. They are allergic and antigen response. They make up 0.5% of the white blood cell count, and they excrete 2 chemicals that aid the body's defense. Histamine. Histamine is responsible for widening the blood vessels and increasing the flow to the injured tissue. It also makes blood vessels more permeable, so neutrophils and clotting proteins can get into the connective tissue more easily. It also produces heparin. It's an anticoagulant that inhibits blood clotting and promotes the movement of white blood cells into an area. And now on to the monocyte. Monocytes are a bit like a vacuum cleaner, but they also remind me of sniffer dogs, always out there on alert, looking for things that shouldn't be there, picking it up and bringing it to you and saying, look what I found. Have you seen this before? What should we do with it? I always think they're really quite pleased with themselves, thinking of they've found that out there. And then they say, what shall I do with it? And then they can hoover it up. So it's a similar vacuum cleaner, the proper word for that is the phagocytosis function of the neutrophils. Like I said, they present the pieces of the pathogens, the bacteria or fungus to the T cells, and then hopefully they can be recognized again and killed appropriately. So now onto the lymphocytes. They are much more common in the lymphatic system than in the blood, and they consist of B cells, T cells, and natural killer cells. They are highly specialized defender cells, and these specially selected cells quickly multiply, creating an army of identical cells to fight the infection. Special types of T and B cells remember the invader, making you immune to a second attack. So these do help you with the immunity. They remember things from before. So when that sniffer dog shows it to them, they say, yes, I've seen this before. I know what to do with it. This is your immunity. Now onto your platelets. They are sticky and stick together. The normal platelet count is 150 to 400. Ultimately, their job is to clot the blood and stop you bleeding to death. So now we're going to meet a patient, Lucy. She's not really called Lucy, but I much prefer it than patient X. So she's 35, and she's just got back from her holiday in Ibiza, but it's taken her a bit longer than usual to get back to normal and back into the swing of things. She feels it's more than just post-holiday blues, and she has 2 small children at home, and they keep coming back from nursery with bugs, and she seems to be picking them up too. So she goes to her GP and explains these symptoms, and they, of course, take a full blood count. Her hemoglobin is 10, a little bit low. Her white cells are a little bit raised at 13.8. Newts are 2.09, and platelets are 148. Nothing too unusual there, but there are some slight changes. So let's have a think for a moment. The slightly low hemoglobin, could it just be anemia? We can check some other blood tests, iron, folate, vitamin B12, see if she's deficient in anything of those. These all help produce the red blood cells. Is she a vegetarian? Hasn't she been eating well recently? And then the high white cell count. Could that be a sign of infection? Just a general infection? There's another marker we can use, CRP. It's a crude marker of inflammatory response. Give that a check. But then we can use these full blood counts to aid in our diagnosis. So this abnormal FBC count leads to a referral to a haematologist. And they go on to do more diagnostic tests. They complete a blood film and a bone marrow. Unfortunately, Lucy is diagnosed with acute myeloid leukemia. And because it's acute, she moves on quickly to treatment, and she has a course of chemotherapy. So now I'm going to explain the use of FBC monitoring during treatment. So as we know, chemotherapy targets all rapidly dividing cells. And at this point, all 3 lineages would be affected, often leading to pancytopenia. So that's the lowered, all 3, so the red cells, the white cells, and the platelets being lowered. Also a result of standard chemotherapy are all other cells fast-dividing cells being affected. So we have the standard chemotherapy effects of hair loss, sore mouth, diarrhea, all rapidly dividing cells. So we know the cells are going to be low, but what are acceptable? What are acceptable counts for our patients? And when do we need to begin to worry and think there's something we need to do about that low count? So when should they be treated? When should these low counts be treated? And how should they be treated? So the values I'm going to go on to explain will vary from hospital to hospital, but I'm going to go with the usual acceptable low counts. So red cells. Our cutoff normally is 80 and less. Some centres will stretch to 70, which leads me on to a very important point about how is the patient feeling? Are they feeling symptomatic? And by that I mean, are they feeling fatigued? They can't get up the stairs. They're struggling to get out of bed in the morning. Do they feel dizzy even though they're drinking plenty of fluids? And often patients report to me, I've got this thumping in my ears. And that will also prompt me to thinking that they'll need a blood transfusion. This is very individualized. We need to look at each patient uniquely. I may have one patient walking around with a hemoglobin of 60 and they feel absolutely fine. And then I have another at 80 and they're actually struggling. This is when you need to assess your patients and act as an advocate for them. I've been known to ring a blood bank before and say, I need a unit of blood for my patient. And they say, well, what's their hemoglobin? And I say, it's 80. And they're like, that's absolutely fine, leave them alone. And I'm like, you haven't seen this patient. They can't get out of bed in the morning. They can't get up the stairs. They need this unit of blood. And then you've got to think that some patients are actually against blood transfusions. They're not without their risks. So if they're feeling okay at 70, they're getting out of bed, they're doing their normal things on their own, then just good close monitoring and communication, and they might get away with it. Another is shortness of breath, and like I said, specific to each patient, and we would support with a blood transfusion. So next I'm going to talk about platelets. So 20 is our normal cutoff. We would support with a platelet transfusion if they're less than 20 and high risk of bleeding or already bleeding. Brushing their teeth in the morning and there's blood when they spit, nosebleeds when they blow their nose, when they go to the toilet, that blood's there, then we'd probably give them a pool of platelets. And if they're septic, if they have a temperature, their need for platelets is greater. If they're going for a procedure, an endoscopy, we like to give all our chemotherapy through central lines, and then normally the departments like to have the the platelets above 50. So we would give a transfusion beforehand, take an FBC beforehand, note that it's low, give a transfusion, and then like an increment level to prove that it's above 50. And some places like to actually have a pool of platelets running during the procedure. And white cells. In particular, neutrophils. So, severe neutropenia would be less than 0.5, and neutropenia would be less than 1. And at this point, we would have good infection control measures. If possible, we would isolate the patient, advise good hygiene. We would encourage visitors because it's good for mental health, but if they are unwell with infective symptoms, then we'd ask them not to visit. If they're out at home, which we do allow them when it's above 0.5, we advise don't go to crowded areas, don't travel in rush hours, and follow the neutropenic diet. So no blue smelly cheeses, fruits and vegetables that you can wash, and well-cooked food, probably not from the takeaway down the road. And in the UK, we advise to drink tap water over bottled water from natural springs. And where appropriate, we can support the neutrophil count with a growth hormone injection called GCSF. So let's look back to Lucy. So Lucy is at home following the first course of her chemotherapy. She calls the hospital saying that she last had her chemotherapy 10 days ago, and she has a temperature of 38 degrees, and she's feeling short of breath. The advice from the hospital is to come in immediately. So on discharge from chemotherapy, we give patients a number to call if they're feeling unwell. There's a number Monday to Friday, 9 to 5, and then we also have an out-of-hours number. And then we always say, if you're in doubt, then call for an ambulance, call 999. So she comes in and we take an FBC. And this shows her hemoglobin is 79, her platelets are 12, and her neutrophils are 0.1. So immediately she's treated for neutropenic sepsis with IV antibiotics. She's also given a platelet and blood transfusion. She said she was feeling a bit short of breath, she could do with a unit of blood. Platelets are 12, so they're less than 20, and she's septic. She needs to have a transfusion. So post-chemotherapy, we would expect the marrow to regenerate the FBC counts and pick up and be stable. We'd expect it to do that on its own. We can then go on to the next course of treatment, which for Lucy would be an allogeneic transplant from a donor. So let's just familiarise ourselves with the timeline of the transplant. So the minus days are all of what we call the conditioning. The conditioning chemotherapy that sometimes can include radiation. So they're all the minus days. The 0 day is the big day, the day that they get their stem cell infusion. And then any day after day 0 are the positive days, the plus days. And I'm going to talk about what the FBC would be doing throughout these days. So here we are, FBC during your bone marrow transplant. So the course of chemotherapy is given to prepare the marrow, to clear the marrow. This is usually about 7 days. And the objective of the conditioning therapy is to destroy the patient's stem cells, to make space in that bone marrow for these new donor cells to come in and home, and also to kill any leftover malignant cells. Also designed to suppress the patient's immune system and to reduce their risk of graft rejection. We would expect counts to be stable during this time until the effects of the chemotherapy take hold, and then we would expect pancytopenia, all 3 lineages, to drop. So when would we expect the FBC counts to drop? Probably about here, day +5. And we know they're not going to pick up until engraftment happens. So we need to support the patient at this time with platelets and red cells and following infection control precautions. Now let's talk about engraftment. So on this day here, day +7, we'd give that GCSF injection, that hormone injection to boost the neutrophil count, to encourage the bone marrow to start producing new cells. And we would expect engraftment to happen day 10 onwards. There we are, day 10. So why are we so bothered about engraftment? Well, it's everything we've been waiting for. It's the first sign that all of this has worked, and it's the beginnings of the new marrow for the patient. So engraftment is these new donor cells making their way to the bone marrow, where they will start to grow and mature into a normal full blood count. This is the engraftment. Normally takes about 10 to 20 days, but depends on the type of stem cells used, and it's likely to be different for different patients. So what do we class as neutrophil engraftment? It's the first 3 days with a neutrophil count above 0.5. Why are we so obsessed about the neutrophil engraftment? Well, as clinicians, we know that the first line of defense against a bug is there. And why is a patient so bothered about their neutrophil engraftment? Well, it's the signs that they can start to think about going home. We have a little bit of peace of mind when these neutrophils come up, that they have a protection against some of the bugs out there. But saying that, I'm sure you all know that the biggest risk to patients is the patient themselves. We all have bugs that live harmoniously on our skin, in our guts, and take the immune system away, and those bugs can run riot. Anyway, for the patient, this means they can go home soon. I'm now briefly going to talk about platelet engraftment. And before I came in to do this talk, I quizzed the data managers in my office. I said, what would you find useful in a presentation? And this is a common theme, actually, because documenting the actual time of platelet engraftment can be quite tricky, especially as this sometimes only truly happens after discharge. And I say truly because platelet engraftment should be documented to have happened once the platelet counts is above 20 for 3 days unsupported. Now that's the key. Unsupported means 7 days without a blood transfusion. And because this often happens when a patient is discharged, we often do shared care with other hospitals, and we don't know if the other hospital has given them a pool of platelets, so we can speak to our blood bank, and they can tell us when the last pool of platelets we issued was. But the only true way to know is to speak to the local hospital if they're having shared care there as well, and see if they've had any issued. So what can affect the engraftment time? So the CD34 count, that's the number of stem cells that was infused. The stem cell source, so are they a bone marrow, or is it a peripheral blood, or is it a cord? All of these things affect the engraftment time. Conditioning, the intensity of the conditioning that was given, how much the bone marrow was affected. Infection, some infections, especially viruses, can be myelosuppressive. And immunosuppression, we give immunosuppression to all of our patients in the form of cyclosporin, but this needs to be tapered correctly. Too much or too little can affect the engraftment time. And the use of medication. Our transplant patients are highly medicated, and some of these medications are, as just a side effect, myelosuppressive. And age. The older you are, the older your bone marrow is, and the longer time it could take for you to engraft. So let's go back to Lucy. So she had a 10 out of 10 CMV, so that's a virus, and ABO, so that's the blood group, matched allogeneic transplant, unrelated. So for an unrelated donor, this is the best you can have. She had limited complications during her inpatient stay. She had the expected and treated infections. And let's have a look at what her counts did during her transplant. So on admission, which was day -7, her counts were fine. Hemoglobin 111, white cells 3.85, platelets 230, and newts 2.35. This shows that she has a recovered marrow from her previous chemotherapy. So she has had 7 days of chemotherapy, conditioning chemotherapy to receive the cells. On day 0, you can see her counts, they're okay, they've dropped a little bit, which is what you'd expect. And then on day 7, which is the day you start the GCSF, the hormone injections, you can see she is neutropenic. We should say 0.95. She is neutropenic. And then engraftment happens over the next couple of days. So day +11, the newts are 0.75, day +12, 1.54, and day +13, 5.95. These are 3 days of the neutrophil counts being above 0.5, which means she's engrafted. And she is discharged on day 13. So how does a patient feel during their inpatient stay? So I drew this graph a little while ago for another presentation that I did, and I wondered about its relevance in my presentation today. But I thought about it, and I actually use a neutrophil count, which is part of the full blood count, as an anchor, as a marker, as how the patient would be feeling. Often my patients say to me, Izzy, when am I going to feel at my worst? And I explain that, and I answer that question by using an FBC as a marker. My answer is when your counts are low. You can easily pick up infections. So let's have a look at this chart. It's not something scientific, it's something I just drew. So when we admit them, they're often feeling okay. You can see the smiley face there, they're feeling all right. And then over time, when their counts drop, they start to feel unwell again. And then they start to feel a bit better, but not quite as good as they were when they first came in when we get to discharge them. As the effects of the conditioning chemotherapy take hold and their counts drop, they start to feel rotten. And as time goes on, their counts pick up and they begin to feel better. But like I said, probably not as good as they felt when they first came in, but well enough to go home. So as I'm sure you're all aware, the aim of the transplant is to create a functioning marrow. So those stem cells I mentioned at the beginning, this time from the donor, can make all the cells needed. The white cells, the platelets, and the red cells, and hopefully with no cancer cells left behind. We continue to monitor the full blood count post-transplant. So twice weekly, immediately post-transplant, and the further away from the day 0 they get, this reduces down and their count should stabilise. They may still require blood product support, and yes, they've got their neutrophils there, but the rest of their immune system is developing, it's growing. It's like you've pressed a reset button. It's like it's been reborn again. It still needs to relearn. We do expect a fluctuation of full blood counts during the post-transplant time, but that should stabilise. And then we do continued lifelong monitoring. So a change in the FBC can be the first sign of disease relapse, and it can prompt us to do a bone marrow. And also graft failure or loss can manifest in falling full blood counts. So primary graft loss will be when they never engrafted in the first place, and secondary is when they drop their counts once they have already previously picked their counts up. And then we added another test, regular bone marrows and a chimerism. So a chimerism is the percentage of donor cells versus your own cells. And when I first put that word into Google, I saw there was a Greek mythology called Chima, and that's a hybrid creature with more parts than one animal, so multiple animals. And I suppose that makes sense. The patient has a body of themselves, but the immune system and cells of another person. So I'm quickly going to talk about full blood counts in autologous transplants. So that means that their own cells are used. They are harvested previously and stored, ready for use. And this ultimately allows us to give really, really high doses of chemotherapy. And this would cause the full blood count to drop probably beyond repair. If we were to give these high doses of chemotherapy and just leave the patient alone, their marrow would be so suppressed and their full blood count would never recover. But having previously stored those stem cells, we can rescue them and allow those new stem cells to go in and recover their marrow. It's kind of like a parachute, a rescue. So if you remember one thing from my presentation today, I want you to think about this debate, that it's not all about the numbers. Treat the patient, not the number. How is the patient coping with a low hemoglobin? Do they really need that blood transfusion? Assess the patient each time a blood transfusion is suggested. The only time we really need to treat the numbers is when the patient has a low neutrophil counts and a high temperature. You really, really will need to treat those numbers. So I just wanted to talk about something that a patient mentioned to me, that during their transplant, they had this love-hate relationship with their full blood counts. They can become obsessed. For them, it's the answer of whether or not they can go home, whether or not their transplant has been successful, whether or not they need to be hooked up to a blood transfusion for the next 4 hours. I've had patients say to me, just don't mention full blood count. I just don't want to know. I've heard enough about it. And I've had others that have become so obsessed that they plot it on a graph, make a color-coded spreadsheet. On the ward at King's, we have whiteboards in all of the patient rooms, and sometimes the nurses write the counts on there, counting down the days that they can go until they can go home. And other patients just would rather have a smiley face written on that board. Who knew so much emotion could be attached to a simple blood test? It's not really so simple. So in conclusion, FBC is I don't think simple. I think the word in there should be common, but it tells us so much and means so much for the patient. It can point us in so many directions for patient treatment. Any questions?